Our next section is section 6, and in this section we are going to look at Tallipcs, Genuvalgum, and then Genuvarum. And it seeks to introduce students to Tallipcs, Genuvalgum, Genuvarus, and musculoskeletal system tumors. And bone tumors, as we know, are usually managed by surgical means, and thus pre-op preparations such as dealing with self-image and other post-operative management should be taken into consideration. For the outline of the session, we are looking at the definition, the types, the incidence, causes and risk factors, clinical manifestations, diagnostic investigations, management, both surgical and non-surgical, specific nursing management, and with this we talk about pre- and post-operative management or care, and then complications associated with them. Students should be able to differentiate between Tallipcs, Genuvalgum, and Genuvarum. Should discuss signs and symptoms of Tallipcs, Genuvalgum, and Genuvarum, and then describe the treatment modalities with bone tumors. Our first topic is Tallipcs. People call it Tallipcs or Tallipcs. It is a congenital deformity which involves one foot or both, and the affected foot looks like it has rotated internally or externally at the ankle, and the affected patient cannot stand with the sole of the foot flat on the ground. In Tallipcs, or this is also known as a clamp foot, the bones of the feet are abnormally shaped, and the Achilles tendon or the large tendon at the back of the heel becomes tight. So if we take Tallipcs, we may have equinovarus as in club foot, and then Tallipcs calcaneovalgus. So Tallipcs equinovarus or TEV. In this, the affected foot looks like it's been rotated internally at the ankle, and it may be classified as postural TEV and structural TEV. The structural Tallipcs equinovarus occurs as a result of genetic factors such as Edwards syndrome. Normally, the affected foot is shorter and the calf muscles are thinner than normal. And postural Tallipcs, on the other hand, occurs due to the position of the baby in the uterus. It shortens and tightens the soft tissues, including ligaments, tendons, and muscles around the baby's foot. So in the picture, we have Tallipcs. The patient's feet or toes rotate inward towards the abdomen. So that is the baby with Tallipcs. Tallipcs calcaneovalgus. With this one, the affected foot looks like it has been rotated externally at the ankle, and the calcaneovalgus also results from uterine positioning, and the plantar surface of the foot is against the wall of the uterus, and this forces the foot into dorsiflexion. Again, remember your anatomy. Positions, various planes or positions of the body: plantar flexion, dorsiflexion, external and internal rotation, etc. So that is the calcaneovalgus in the picture. The incidence is 1 in 1,000 babies, and it's twice as common in boys than in girls. Genetic predisposition means that it may run in families, and there may be associated abnormalities elsewhere in the body, especially with bones. So in 50% of cases, both feet are affected. Over 80,000 children are born in developing countries each year with club foot, many of whom go untreated. Now let's look at some of the causes and risk factors. It may be genetic, as in Edwards syndrome, or oligohydramnios or amniotic band syndrome, abnormal pressures compressing the foot during development, breech presentation, spinal bifida cystica, teratogenic agents, cerebral palsy. All these are also risk factors to the development of club foot. Now the clinical manifestations. The symptoms depend on the type of Tallipcs. The ankles of the affected foot may be either externally or internally rotated, and the calf muscles of the affected limb may be thinner than normal. So the foot of the affected limb may be smaller than normal. How is it diagnosed? Development ultrasound scan is normally done around 20 weeks of gestation, and x-rays of the feet may also be done. Now the treatment. Tallipcs need prompt treatment whilst the baby's tissues are still soft. Postural TEV requires a physiotherapist to exercise the foot to regain its normal position. However, in structural TEV, the foot is manipulated for several months towards the correction position, and methods such as casting, splinting, and the use of boots and bar are used. So that is a child being taken through feet exercise by the physiotherapist. And this is a picture of a child in bilateral long leg plaster cast for club foot correction. This is the boots bar, a child with boots and bar for correction. Surgical interventions may include reconstructive surgery, and this is performed between 6 months and 1 year if non-surgical methods fail to correct the deformity. So initially, patient is taken through physiotherapy exercises. A cast may also be applied. And the prognosis, approximately about 50 to 60% of club feet in newborns can be corrected non-surgically. However, about 20% of infants requiring surgery need further treatment at a later stage. Now, our nursing care. The nurse is expected to educate parents on condition and treatment. Sometimes parents of these children think that the children are strange children, maybe given to them by God, certain water, or a God somewhere. So they need to be educated and explain to the parents that the baby's feet and legs might look a little bit swollen after applying the cast, but this is normal and it's going to settle down once the plaster has been off for a few days. And the procedure should also be explained to parents, and babies become upset when they are first put into the boots and bar, which is usually not because they are in pain, but because it's a new experience and they don't feel comfortable. So let the parents know that the babies are going to feel uncomfortable and may cry excessively or become restless. Then the patients or the parents of the child should be instructed that the boots and bar must be worn for 23 hours per day for the first 3 months, and that they can only be removed for a maximum of 1 hour per day. And this may be removed during birth. Patients should be educated that after 3 months, the boots and bar are worn just at night, and this must be for a minimum of 10 to 12 hours per night. Plus, when the child has any long naps during the day or during long car journeys, parents should also be shown how to fit boots and the bar at home. We now move on to our second topic, and that is Genuvalgum and Genuvarum. Genuvalgum, commonly called knock knee, is a condition where the knees angle in and touch one another when the legs are straightened, and individuals with severe valgus deformities are typically unable to touch their feet together while simultaneously straightening their legs. The mild genuvalgum can be seen in children from ages 2 to 5 and is often corrected naturally as the child grows. However, the condition may continue or worsen with age. So in the picture we have genuvalgum, a child with knock knees or genuvalgum. All these are pictures showing genuvalgum. Now the causes. It may be due to rickets, obesity, it may be congenital or idiopathic. The cause may not be known. How do we diagnose this? The degree of genuvalgum can be estimated by the Q angle, which is the angle formed by a line drawn from the anterior superior iliac spine through the center of the patella, and a line drawn from the center of the patella to the center of the tibial tubercle. In women, the angle should be less than 22 degrees with the knee in extension and less than 9 degrees with the knee in 90 degrees of flexion. However, in men, the Q angle should be less than 18 degrees with the knee in extension and less than 8 degrees with the knee in 90 degrees of flexion. And the typical Q angle is 12 degrees for men and 17 degrees for degrees. So henceforth, if you come across any patient with genuvalgum, I would entreat that you look at this angle and know the degree. Now it's surgically managed. It can be surgically managed, and the surgical management involves microsurgery, open reduction with fixation or ORIF, closed reduction with cessation, reduction and application of POP, and then reduction and application of skeletal traction. So this is a picture of how a genuvalgum can be corrected. Even after correction, you still have the leg not being very straight, but then there's a great improvement. Then when we look at Genuvarum, which is also known as bow-leggedness or bandiness or bandy leg, and tibia vara, is a physical deformity marked by outward or bowing of the leg in relation to the thigh, and it gives the appearance of an archer's bow, and the affected bone curves out and forms the usual arc or archer, which can be called bow legs. So that is Genuvarum in the picture, and the causes again include rickets, skeletal infection and tumors, physical trauma, and it may also be idiopathic. Generally, no treatment is required for idiopathic presentation at a normal anatomical variant in young children, but treatment is indicated when it persists beyond 3.5 years. And when caused by rickets, the most important thing is to treat the disease, and at the same time instructing the caregiver never to place the child on his or her feet. It can be hastened by applying splints, and when the deformity arises in older patients, either from trauma or occupation, the only permanent treatment is surgery. So surgical procedures used may be the same as for genuvalgum as discussed earlier. Now the specific preoperative nursing care. Patient or the child's mother, if it's a child, needs to be reassured, and the procedure needs to be explained to them or to patient's mother. Inform patient and relatives that they will stay in the hospital for about 2 weeks to 3 months, depending on the type of surgery. So this is the psychological aspect of our pre-op preparation. You know, we have the psychological, physical, we also have physiological, and spiritual and social economic, which have all been discussed. So you apply to this situation, but specifically we want to know what to do as regard to the surgical management of a patient with this condition. And the nurse ensures that all requested investigations such as x-rays are carried out, and patient is informed that the extremities will be elevated to reduce swelling. Patient and relatives should be taught post-operative exercises. So patient is taught as to how to do deep breathing exercises and use of crutches if necessary, and inspect the skin for abrasions and circulatory disturbances. The skin and circulation must be in healthy condition in order to tolerate the traction. Personal hygiene must be maintained before applying traction, making sure that the extremities are clean. And then the patient should also be informed that he or she should take showers within 5 to 10 days of pin insertion. Then the sites are dry with a clean towel and left open to air. We want to do all these in order to prevent infection. Specific post-operative care, patient is instructed to report any changes in sensation or movements immediately so that they can be promptly evaluated. And then there's also a need to assess the neurovascular status of the immobilized extremity at least every hour or hourly initially, and then every 4 hours as the condition improves. The pin sites care is individually prescribed and performed initially 1 or 2 times a day using normal saline and cover with povidone iodine dressing. And then you inspect the pin site daily for reaction, that is normal changes that occur at the pin sites after insertion and infection. Patient is also assisted to perform post-operative exercises to maintain muscle tone and strength and also improve circulation. Now let's look at some complications associated. This may result in decubitus ulcer. Post-op complications, we may have decubitus ulcer, atelectasis, pneumonia, constipation, urinary stasis and infection, and then venous thromboemboli with deep vein thrombosis or pulmonary embolism are all possible post-operative complications. In conclusion, Tallipcs, Genuvarum, Genuvalgus are usually congenital abnormalities, and after surgery, periodic assessment of the neurovascular status of the immobilized extremity is key or very important. Please refer to the reference list or reading list. Thank you.